Good evening, everyone, and welcome to the first webinar of our 2025 Better Billing webinar series, New GP Registrar, Starting in the Land of General Practice. My name is Jade Buller, Workforce Development Officer at Western Victoria Primary Health Network, and I'll be your facilitator for this evening. Alongside me is Erin Crimmins, also from the Workforce Development team here at the PHN. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations. You can view majority of our webinar recordings freely on the PHN Learn YouTube channel. We'll put a link to access them in the chat. Please see our upcoming events on the screen now. You can also register for these events via our website, and we'll also put that link into the chat for you. A certificate of attendance will be emailed to participants. Please take a moment to check that your full name is displayed accurately on your screen. If not, or if you're unsure, please rename yourself or type your first and last name into the chat box now. This will ensure we can issue with a certificate of attendance. This event is being recorded. Please keep yourself on mute unless you'd like to ask a question during the designated question and answer time, which will be at the end of the formal and presentation. We encourage interactivity and discussions, so please feel free to type questions into the chat box at any time. Your feedback is extremely important to us, so please take the time to complete the event survey after the webinar. There will be a link in the chat box to complete the survey, and we'll also re-display this QR code. Our presenter for this evening is Ashley van Leeuwestyn from Better Billing. Thanks, Ash. We are delighted to have you back.
Thanks, guys. I'm just going to start to share my screen, so just bear with me 1 second. Okay. All right, so hopefully we're all good and we can see the start of my screen here. So tonight is a talk that I'm sort of dedicating to new GP registrars that are sort of starting in the land of general practice, and the hope is that tonight they sort of learn a little bit about some basic billing and a little bit of preparation and a little bit on consult structure and a bit on what I wish I knew at the start of training. So we'll get started. Please, if you have any questions, chuck it in the chat box for me, and then I can answer them at the end, and Jade and I can go through them. But yeah, so we'll get started. So this is what we're going to go through tonight. So a little bit about what is Better Billing and who am I. So if you've done any of my webinars before with these guys here at the PHN, then you would probably have an idea. Medicare, a little bit about Medicare and what Medicare is. So you don't really learn much of this until you enter general practice. What I wish I knew at the start of my training, a little bit on basic consult structure, but not a lot. Then we kind of go into some billing basics, a little bit about my Medicare, and then a bit about calculating pay. And then at the end, I've got a little bit of a to-do list of what should I do from here? These are the things I sort of recommend. So I'm Ash. I'm a GP registrar. I'm just towards the end of my training now. I've got a few months left, and I'm based in New South Wales. I am the RLO lead, which is the Registrar Liaison Officer for the college, but I'm also the owner and creator of Better Billing, which is an online-based education platform for MBS education. So a little bit about what is Better Billing. So we've got a whole heap of different things that we kind of do, but focus is predominantly on online courses. They're on demand, ready to go and they're targeted towards GPs, GP registrars, practice managers, and quite recently, quite a few of a few nursing team are quite interested in this as well. We also offer templates, which are sort of about preparing your note-taking skills to a point that kind of get it a little bit more streamlined. We do offer one-on-one coaching as well, and then presenting, which is what I'm sort of doing tonight. So let's get stuck into a little bit about what is actually Medicare. So Medicare is, for those who have never experienced the system, maybe weren't born here or haven't really had a lot of time in in the hospital system, in the healthcare system. So in Australia, we have tax called the Medicare levy, which is approximately about 2.9% of our budget. And in that is where GP rebates come from. So GP rebates are essentially a taxation derived payment, which we will go through a little bit tonight. As a GP, it is really your responsibility and also paramount to your survival to learn about GP rebates and learn about the MBS, or the medical benefit scheme, which hopefully I can sort of shed a bit of a light on the early bits of today for you. And if not, then maybe looking to help you in the future around direction on improving your own billing. So what is, everybody sort of says at the start, what is bulk billing, what's private billing, what's mixed billing, what's all of this? So this is a little bit of a table, but essentially bulk billing is where patients are not charged out of pocket. So the GP will bill Medicare directly. So there's no out-of-pocket cost for the patient, and the entire cost of the consultation is covered. Generally, this is available to anybody who has a Medicare card. If they do not have a Medicare card, they cannot ultimately be bulk billed. Typical usage, we kind of see in a lot of low socioeconomic status areas, or where patient affordability is a big concern. A lot of our practices are mixed billing. So this is a combination of bulk and private billing, where patients can sort of be charged a gap fee depending on circumstance. And there might be a group of patients who are bulk billed, so quite often children or DVA Gold card holders, concession card holders in some places, will vary, and those who don't fit those circumstances are charged what we call a doctor's fee, and that's paid with their rebate, and the gap payment is what they're left owing. So that's what they've actually had to do out of pocket. So there's a whole host of mixed billing locations. And then you sort of have your private only billing practices, which are pretty rare. And that's where no matter who is being seen, the patients are all being charged privately. Bulk billing is normally not something that is offered. So for a lot of us, it's mostly about figuring out the difference between mixed billing and bulk billing. So what I wish I knew in the first few weeks. So a lot of things, when you first start general practice coming from the hospital, it is really quite daunting. And if you have already sort of started in the last month, well done, you're still sitting there and you're still going. It is really quite stressful when you make that transition. And there's a few things that I really wish I already knew at this point. And the first is that your supervisors tend to expect to chat with you all the time. It's almost a red flag if someone doesn't expect to chat with you, with their registrar, their early registrar, quite often. It's also okay to say to your patients, can I let you know or about this another time? Or can I go and read about this and then come back to you? I feel every time when I've actually used that line in early days of being a reg, even now, they're kind of impressed that you want to go and spend some time reading up about their symptoms or their condition. Another thing, I need to be reminded of this all the time, is that general practice is a marathon. It is not a sprint. So go slow, slow is smooth, and smooth is fast. So that's one thing I need to even hear as well. GP is an awesome career and really can be whatever you want it to be. So, I mean, I do a combination of this. I do a lot of women's health, long-acting contraceptions, marina, and skin cancer stuff. So I just have a whole range of patients that I see all the time, and my weeks look like how I want them to look, and know that general practice slowly but surely will find its niche in you, and then you'll start to realize I can have a really cool and diverse week. So also, once I moved to general practice, I quite often found that patients and fellow staff really appreciate you way more than you think, and you hear about this appreciation a lot, and it's really quite a welcome change if you've come from the hospital environment. So if you haven't noticed it now, give it a few weeks and people will start saying, I'm really glad I found you, and it's really nice. Some links on the left hand side of stuff that is my bread and butter. I use it every day. Health pathways, which your PHN is heavily involved in the creation of, your ETG, your therapeutic guidelines, your AMH, which is again, we all have use of links. And in the corner there is our MBS cheat sheet, which we'll go through tonight, and you'll be able to sort of see the QR code to download, which is a really good option to just have on your desk when you're thinking about, oh, what's that code? I know there's a code for this, but it takes you so long to find it in the MBS. So I have made my own cheat sheet, which I think is encompasses all different types of ways that you have your consultation, and a lot of missed and forgotten numbers are on there as well. So consult structure, I'm not going to focus on this too quickly. There is a link here in the QR code with a RACGP article, which is really great about how to think about your consult structure in general practice. Very commonly, I used to hear that ED is just like, ED fast track is just like GP, and it's absolutely nothing like ED fast track whatsoever. So have a bit of a read, try and get your own consult style. You're in the early stages now. You can absolutely try all different ways, different openers. How would you like to start the consult? What would you like to do? Have a look at that article. It gives you some really good ways to not miss anything, but also help you find your own style. So let's get into the basic billing. So this is the things that we're going to talk about tonight. So please, if you are a absolutely seasoned pro of the MBS or a GP of many years, you are going to probably be a little bit bored, but this is going to focus on basic billing structure. So you can see here, this is an excerpt straight from our cheat sheet. So the QR code in the bottom right here is a direct link to our website where you can download it for free as a PDF. So I have this ready to go every day and use it every single day. And what you can see here is the item numbers that are split up by face-to-face, video, or phone. So item numbers as well are also split up by time-based consultations. But I would dare say by now you guys would get used to the idea that, okay, I often charge a 23 or a 36 or whatever it might be. In terms of the mental health care plans and mental health consults, these numbers that I've used are for those who've completed the mental health care training. So I'll make a bit of a mention of that at the end of the talk tonight. But you'll be able to sort of see that those mental health care plans that are under the mental health training, you attract better rebates. So it's quite useful from that point of view, but also it's actually pretty decent training about how mental health care plans are created and how you make a formulation and impression. So these numbers that I'll be talking about tonight are for those who have completed the training. And then you've got here on the bottom is the investigations. And these are just investigation numbers for common things that I would often do in practice. So a urine beta HCG or a urine pregnancy test, spirometry for diagnostics or monitoring, an ECG, and an ABI, which is an ankle brachial index, which not a lot of practices have. However, if you have a machine, it is a great code to be using. So what we're going to do tonight is sort of explain the common scenarios that you might start to see that help prevent you from getting exceptions from Medicare early on. So the first thing I want to talk about is separating these three subtopics in sections. So the first bit is a green circle, and when these green together can be billed together. So you can see here that you've got your general attendance and then you've got investigations. So an example might be that you're seeing a patient and you've decided that they've got some chest pain that you would really like to do an ECG on. So as you can see here, your ECG number is 11707, and say that you've spent 27 minutes with the patient in consultation. What would happen is you would bill a 36 as well as a 11707. So you can see here that there is no rules to say that you cannot bill these item numbers together. The great thing about investigations is that they can be billed with any other item. There's no rules that you need to know about investigations. They can be billed at any time. So if for some reason you might end up having a patient who gets a mental health care plan on the same day as they might get monitoring spirometry, those number items can be billed together. Mental health care plans are very clearly time-based. So in these cases, it's 20 to 40 minutes. So a minimum of 20 minutes needs to be spent with the patient making the mental health care plan, or more than 40 minutes of a mental health care plan. As you can see, there's the 2717. You can also review mental health care plans, which is going to be removed later on in this year. However, at the moment, they are still relevant, and those are not time-based. So you'll be able to see in all of my cheat sheet that if something has a time-based code with it, it'll be noted. So you won't feel, if you have something that requires 20 minutes, you will see it will be on that sheet. Then there's another code there, which is the mental health review, and that's more than 20 minutes talking with a patient about their mental health. So this means that they're not a mental health care plan has been created, but you've ended up speaking to a patient for more than 20 minutes about mental health related conditions. So what we're going to do from here is have a bit of a chat about co-billing. So co-billing, and this is a very small introduction to it. So there's two terms that you would have maybe heard, or if not, you will definitely hear, and that is co-billing and split billing. So co-billing is when the combination of numbers are entered to Medicare at once. So for example, like I mentioned before, you've got the 23, which is your general consultation item number, and the 11505, which is the spirometry number. So these things can be code billed. Then what you've got here at the bottom, you can see some things in green that I've said these can be co-billed, and general attendance items can be co-billed with your investigations, like I mentioned. And another thing is the COVID vaccination assessments. Now, these will not last forever as well. These are going to be removed later in the year as well. However, at the moment, the code 93644, for example, can be billed at the same time as the general attendance. Things you cannot co-bill. So you cannot co-bill a general attendance, which is a 23, 36, 44, with care plan creation or care plans, health assessments, mental health care plans, or antenatal visits. Now, you'll see here that there are exceptions to that rule, and we'll run through some of the exceptions. But in general, the exception is if the general attendance, so for instance, an emergency situation has happened, or someone is acutely unwell with an acute illness that cannot be waiting for the next available appointment, then that is viable for you to be able to send to Medicare as two separate billings in a co-billing situation. And I'll explain how that happens in a further example. Split billing, however, is great. So split billing is where multiple different services that have occurred at the same attendance but can't be built together. So for example, they need to be split. Now you'll see here the example I've done is a 23 for 7 minutes, and this might have been related to let's make it really separate, and this might be related to somebody's cholecystitis or their gallbladder attacks or their gallstones that have been coming and going. And this is something that's separate, and you've reviewed it and you've said, okay, you know, it might be a post-op check. Yep, you're doing great post-operatively. You know, the wounds look good. Then say, for instance, the patient starts to talk about mental health related things, anxiety, depression, PTSD, and that consultation then ends up being over 20 minutes of mental health. In this case, you can split bill that time. So you've spent 7 minutes on something like surgical follow-up, and then you've also spent 21 minutes on a non-related mental health. At the end of the talk, you'll be able to see that I've got a link to my basic billing course, which is free online. I recommend if you haven't already, have a good look at it. It will explain this process a little bit more clearly with more examples. But for now, this is what I'm going to go through. So let's talk about some examples. So I've got 3 patient examples of common things and what they would look like. So this is a really nice and simple one. So you've got Jan, who's your 70-year-old female patient, and she's presented with shortness of breath. And you decide that Jan, after history taking, might be suffering with COPD, and you'd really like to do spirometry testing on Jan. She's well and she could probably do spirometry at the moment. So your nurse has space and says, yes, I can happily do it. So in this case, you can bill a 23 23 and a 11505. So your spirometry and your general attendance. The general attendance is about the bit where you're talking about your shortness of breath with the patient, and the 11505 is where the spirometry is being conducted by the nurse. Then you might have a situation where you've got Mandy, who's a 27-year-old female, and she comes in and she starts off the consultation saying she wants to talk about contraceptive options. And then after 5-10 minutes into the consultation, you guys have a chat and you figure out that the combined oral contraceptive pill is the best fit for her. Then she also mentions halfway through that, I actually want to get a mental health care plan today too. Now, when I see patients in this way, I often will say that we can't do that today and it needs to be a separate appointment. So quite often I will say, let's make another appointment at another time, and we'll do one separately on the mental health component. I will often say that Medicare has rules that says I can't talk about two things in this consultation, one of them being a mental health care plan. And so as a result, ends up booking a mental health care appointment with me for the next week. Then as a different example, you've got Matt, who is a 24-year-old, what that's meant to say, male, who presents for a mental health care plan to discuss organising psychological sessions for his depression. At the end of the consult, Matt shows you his lower left leg. It's painful, swollen and tender. It's larger than his right, and he's been on a 24-hour flight. So you're worried about a DVT. Now, in this case, you can bill the general attendance with the care plan because this is a condition that it is acute and cannot wait to be seen on a later point. So we can't leave a DVT sitting there just because we've completed the mental health care plan. And so in this case, what happens is you bill the mental health care plan, which code is 2715, and an urgent and required general consultation. And quite often, you will often mention to your reception team, whether that's in your notes at the base of the billing, where you say this is an urgent and required and not related to the mental health care plan. And that is the way that you'll be able to process it through Medicare, and Medicare will understand why you have billed something that cannot be billed together. So a little bit of a mention on care plans. So as a GP reg, you definitely would have heard about care plans. Patients will call them care plans. They're also called chronic disease management plans, aka a GP management plan, aka the free 5 visits. So this item number is 721, and the purpose of a GP management plan is that it's meant to help chronic or complex medical conditions that require ongoing multidisciplinary care. So examples like diabetes, asthma, heart disease, etc. The key points of a care plan is that you're developing goals that are related to the patient and are relevant to the patient, and help them coordinate services for chronic conditions. So that might be seeing an exercise physiologist, seeing a podiatrist, etc. Now, I'm not going to go deeply into care plans. There are a webinar series that's coming up, and we've also touched on it a little bit in the past. So have a look at the webinars or jump on for those. But the biggest point here is whether somebody says, can I get one of those 5 free visits? The point is that the chronic condition needs to last at least 6 months or will be lasting at least 6 months. So if you have Jan who you've just diagnosed with COPD, that's not going to just resolve. So what's going to happen there is you will have a chronic complex condition because this will last longer than 6 months. If, for instance, Jan had community-acquired pneumonia, we know that theoretically that should be gone within six months, so she would not qualify for a care plan. Then you've got the team care arrangement, which is the other half of the care plan. And what this is where this is the referral form that we use at the moment to facilitate the 5 visits to certain places. And that might be a range of allied health professionals. Have a look at a team care arrangement. You'll be able to see that there's about 3 or 4 columns of different allied health professionals who you can refer to. You can split the sessions across multiple different allied health people. So for instance, you might have 2 at podiatry and 3 at physiotherapy. And this team care arrangement is required for patients who need access to allied health. And a really common one that I think of is your diabetics who need to see podiatry, and also may benefit from exercise physiology, or a diabetes educator. For a patient to have a team care arrangement, there needs to be an actual care plan, which is the GPMP component of it, or the 721 that's been completed. If you haven't seen one or haven't done one yet, have a good look, play around on the computer. There's normally in your practice, there's normally test patients that we all call Mr. Tester or whoever, and you can play around in that file to see what these things look like. So ask your supervisor, what's your care plan templates look like? How are you doing that process? And then try and refine it for yourself as well. So a little bit on My Medicare. So My Medicare has only really come out in the last year, and it's starting to really get some traction with practices, and your practice might be quite heavily involved in registering their My Medicare patients. So My Medicare was created for the hope that GPs and patients can make their relationship official, so that your patient notifies Medicare who is my preferred provider as a GP. It's meant to long-term sort of help GPs access chronic disease management item numbers and some longer telehealth consult items. At the moment, it's not the case, but in the future, to access care plans, this will be a requirement. We don't know about other future chronic disease item numbers or health assessments, but in terms of telehealth in the future, there is longer telehealth item numbers also available for those who are registered as your patient through My Medicare. So if you're not sure, have a read about it, have a look. There's lots of PDFs that are made by Medicare about explaining why you do My Medicare. The changes have come from July, so earlier rather than later, you should learn and understand how this is going to implicate for you and your billing in the future. Okay, so this is the one of the bits I kind of help with GP registrars is trying to actually calculate their pay. So it's actually quite hard, because before we would be at the hospital system, we get the pay slip. We know, yep, I did 73 hours this week, so I get 73 hours of, $40, $50 an hour, and that's how I know. But in this case, you've got your regular salary as a GP registrar, which is sort of the safety salary, and then you've got your billings, which you can then go and calculate on a regular basis. That would give you extra pay, or whether you would not get extra pay. But we're going to go through some examples here today about what that looks like. So you can see here on the left side, there's the base rate, and all term run registrars, as per the NTCER, which is the agreement made between employers and the GPRA, or our Registrar Association, has created as a minimum standard for GP registrars. So you can see here the minimum is 91,804 annually, plus your 11% of super. Billings are negotiated with your employer, so not everybody is on the base wage or the base percentage of billings. And think about in the future talking about negotiating billings, because that is something as a registrar you should learn to do, because that will be part of your career for a long time. And what you can see here is, as per the NTCER, they say 49.72% is the minimum requirement of billings owed to the registrar, and which comprises of 44.79% plus the inclusive of super. So this is where it can get a bit confusing. So stay with me. We'll go through some examples, and you'll be able to have a bit of an idea. So quite often there is a confusion between receipts and billings as well. So receipts is where payments are cleared by Medicare and the patients who have paid. Billings is when you've billed an amount to Medicare, but it has not been cleared, or the patient has not yet paid. Not all registrars are paid on receipts. A large majority are paid on receipts. Some are also paid on billings, but know in your contract which one you are being paid, because that will change how you calculate your payment. Now, quite often there's a range of billing percentages that are calculated in a weekly, monthly, fortnightly, a maximum a 3-monthly situation. So we'll go through an example from here. So this is Annie, and Annie is a full-time GP Term 1. She's at a mixed billing clinic and works 4 days a week. She gets paid weekly, but her billings are calculated monthly. This is a very common scenario, okay? So as a result, she's paid $1,765 per week, and her monthly billings that she calculated for her 4 days a week over the last month is $15,000. So what you do is you can see here you've got your billings, and then you've got Annie's percentage, and she's on the base rate here. So that's the 44.79%, which include, and then she will have her super added on. So you'll be able to see here that Annie's percentage has created out of her $15,000 is $6,718. Now, what we need to do is actually take away Annie's wage for the bonus. So you need to essentially pay back the owed wage before you get your bonus. So in this case, if we look at Annie's $1,765 each week, and there's, say, for simplicity, there's been 4 weeks, she's been paid $7,060 over the 4 weeks in wages. As a result, you can see here that Annie's percentage of billings owed is less than what her wage is. And even though she's earned more than $342, she's earned $342 over, it doesn't mean that she needs to pay it back. That's not the case, but there will just be no extra bonuses for Annie during that month. So let's have a look at if Annie did a little bit better. So Annie's gone and done my billing course, and she's done substantially well, and her billings are now up to 27,000 in the month. And what you'll be able to see here is, okay, Annie's percentage, her take out of her percentage is now $12,093. She's been paid her $7,060 from her weekly wage, and that leaves her with $5,033 plus her super. So you can see here that you need to pay back your wage, and you need to calculate your percentage generally without your super, and then your super is re-added back on top. So looking at this this is my last slide, so it is a bit of a quick one, but that's okay. If you want to learn more, that's a direct link to our website. Like I said, there is a free billings course on basic billing and health assessments part 1, which is free on my site, and you're very welcome to jump on. You just need to log on through either a Google, Facebook, or your own email. And on the to-do list on the right-hand side is just some things that as a reg is a really good idea to sort of do in your first term. So log on to Better Billing, have a look at the free courses. Complete the mental health training. So this is through the GP learning platform through RAC GP. If you search mental health MBS training, it will pop up pretty much straight away. And another one that's worth considering completing is the 4001 training, and that is the non-directive pregnancy counselling training. And that, if you are particularly interested in women's health, it's a really good one to do, as people can only access that number once they've completed the training. The other thing is print an MBS cheat sheet. Get your practice guys to help you print it out, make it nice and coloured, laminate it so that it doesn't get wrecked, and have it there on your desk. It is very, very helpful in times where everything is busy and you couldn't be bothered trying to find that number. And look into templates for your notes. So there's a heap on Better Billing templates. I'm a lover of AI. I absolutely love my AI and my Lyrebird that I use every day. The college is making its opinion on AI use in GP Term 1 be known quite soon. But in the future, I would definitely consider looking into it. It is a really good game changer if you're interested. So Jade, what I might do is take some questions.
Thanks, Ash. That was fantastic. There is a couple of questions in the chat. If you just want to have a quick scroll, there's some good conversation as well. Anybody, if you have any questions, this is your time to please take yourself off mute or type them into the chat. We've got one. What is the difference between 11505 and 11506?
Yeah, so 11505 is the spirometry at diagnosis. So if you don't actually have a diagnosis, then that's the code that you would use for a spirometry. So thinking asthma or COPD, and you're investigating, that is the code. The 11506 is for disease monitoring. So if you were monitoring the effects of an inhaler on COPD or asthma, you would be using that code. So it's about whether you've given the diagnosis yet or not.
Great. And how does workplace injury billing work?
Workplace injury, like work cover, that is a very long and loaded question and would have to be an entire presentation. So I'm going to pass on that one. I've seen here, can you co-bill a general attendance and a procedure, i.e. wound care? Absolutely. You absolutely can. That's another really good one. A lot of, regs might be doing that. And a good point to mention, yes, you absolutely can be doing that as well. Brittany writes that she says, I have a 3-month wait. Often the medical and mental health issues need to be covered on the same day because neither can wait 3 months. Does this pass muster? E.g. a 23 with a 2713. Absolutely. Yeah, absolutely. I do this all the time. Quite often I don't have space for a mental health care plan the following week. And you can see here a few people also have got this here that they're agreeing, especially being rural, etc. Absolutely. Yes, definitely. John asks, what is the 4001 MBS training course via GP Learning? So this is a training course for something called non-directive counselling related to pregnancy. So this, I would often use this number for patients who are either considering their options in their pregnancy, whether they're looking to do termination, adoption, having the baby, whatever that might be. It's a 20-minute minimum MBS item number, and it's not about counselling the patient on making the decision. It's about counselling and giving the patient as much information for them to make their own decision. So that's the difference between just a general sort of attendance and 4001. Again, I quite often use it around the decision making of pregnancy, or even I do medical termination of pregnancy, and will often use that time for patients to learn about the options and for them to make the decision. Again, that item number is not allowed to be used by anyone. You do need to do the GP training course in GP Learning, and if you just type non-directive counselling of pregnancy, that will absolutely come up for you. It's an incentive for bulk billing children. A lot of the GPs bulk bill children in the clinic and have mentioned about an incentive. Yes, absolutely. So there is an incentive code now for children under the age of 16 and those with a concession card, that if you bulk bill general attendances, it attracts a larger bulk bill incentive rate. So before it was about $7 every time you would bulk bill a patient with this criteria. However, if you're bulk billing a general attendance for those people who are younger, for instance, children or those with concession or pension card holders, what ends up happening is you get a larger rebate, and it's from memory, I would have to check, but I think it's close to $23 to $25, which is a much better rebate than, say, rebate instead of the 109.90, which was for us is about $7.10. Any other questions? We've got, what's the difference between 93644 and 10660, the COVID numbers? Yeah, so 93644 is a suitability assessment, as it is 10660. So 10660 is something that is much more in depth. So it requires you to be talking about the COVID vaccination for more than 10 minutes with a patient and about whether they qualify. So this is somebody who might have some possible concerns around whether it's side effects or whether they have contraindications to be able to have the COVID vaccine. But it can only be claimed once in a patient's lifetime. So if somebody has a very long, in-depth conversation about COVID vaccination for more than 10 minutes, then a 10660 applies. However, if I was to talk to a patient about, hey, you're up to your 3rd vaccine, would you like to get it today? I've got it here. I can give it with your flu vaccine. the previous vaccines that you've had are going to stop, it's stop being effective for you, and it's a couple of minute conversation, that would be a 93644. The point of 93644 is that you have to have COVID vaccinations in your fridge. And another thing is that the patient does not have to take you up on the vaccination. You can absolutely just have that conversation and they can decline, and you can still claim that item number. Cool. Yes, Brittany is correct. So the 10660 is associated with the 93644 item number. Yep, that's correct. So you would be billing it with the vaccine number. You're quite right that it is impractical because they would go home and think about it before coming back. Yes, definitely. But that is correct. Yeah.
Thanks, Ash. Any final questions? Quickly type them in the chat, or once again, feel free to take yourself off mute. I'll just take this opportunity to highlight we've got session 2 coming up on the 20th of May, which is care plans for nursing staff. And we're going to have session 3 with Ash, Medicare changes with care plans on the 31st of July. I'm betting that will be a very popular topic.
There will be some changes, so just be wary that there are changes coming in July. Team care arrangements are no longer, and care plans are the GP created care plans. We don't know completely what's happening yet, but we do know that team care arrangements are gone. So there will be lots to chat about in that one.
All right. Thanks, Ash. Thanks as usual for a fantastic webinar. Thanks for attendees for giving up your time tonight, and we will see you at the next one.
Perfect. Thank you.
Bye.